So today we're joined by Kerrie Curtis. Kerrie is an expert cancer nurse who's worked in a variety of roles in public and private sectors within inpatient, ambulatory and home care settings. She's recently led vascular access projects at Austin Health, the Royal Children's Hospital and Monash Children's Hospital. Kerrie's got combined expertise in vascular access and cancer care. She's Deputy Chair of Cancer Nursing Society of Australia, Vascular Access Specialist Practice Network, and is a Victorian representative for the Australian Vascular Access Society. She's an adjunct research fellow with the Avatar Group, the Alliance for Vascular Access Teaching and Research in Brisbane, Queensland. Kerrie's recently commenced a PhD at the University of Melbourne looking into premature vascular access failure in the haematology patient cohort, working with Maya Krishnasamy. And today we'll hear from her on Central Venous Access Devices and cancer care, what we know but don't implement. Thanks, Kerrie.
Thanks, Zoe. Hello and welcome everybody, and also to Maya, who'll be online shortly. So Central Venous Access Devices and cancer care, what we know but we don't implement, is the name of the lecture today. So I'd like to start by acknowledging my supervisory panel of Professor Maya Krishnasamy, who is the Principal Supervisor. Professor Sam Keogh who is the vascular access expert and is a Professor of Nursing in Queensland, and also Associate Professor Carla Goff, who is a Senior Applied Health Statistician. So to clarify what a CVAD is, it is a catheter or device inserted into a peripheral or a centrally located vein, which travels through the venous system so that the distal catheter tip resides in the superior vena cava or right atrium. Peripheral veins of the arms and the legs for infants can be accessed, or the central veins in the chest, neck or groin. The difference between an IV or a drip and a CVAD is that the catheter tip is located just before the heart. So CVADs are used for the administration of chemotherapy and targeted therapies, blood products, nutrition, IV fluids, antibiotics, and numerous other medications, but also for taking multiple and repeated blood specimens. There are many clinical advantages for using the one device, and there is positive patient experience as well for reducing needle sticks, pain, distress and inconvenience. However, unfortunately, CVADs come with inherent risks, including catheter migration, occlusion, skin impairment, local and systemic infection, amongst others, and the associated morbidity and mortality. This is a lady I cared for with metastatic colorectal cancer who presented to an outpatient's appointment in between her chemotherapy cycles. At first glance, we saw her face and she tells the story of a full throbbing feeling in her head. But then on further investigation, we detected abnormalities with her implanted portocath site and evidence of a significant infection at the portocath body and tracking along the tunnel catheter up to her neck. On further investigation, diagnostic imaging detected a thrombosis in her subclavian vein, extending into her internal jugular vein, hence the swelling. The impact of the infection and thrombosis was an immediate 2 days in hospital with surgery to remove the infected device, a second hospital visit for the surgical procedure to reinsert another device, and with the associated clinical risks and insertion costs. 6 months of a daily subcutaneous anticoagulant, and pain, discomfort, and bruising from the daily injections, worry and additional time for the patient. So what we know is that there are approximately 13,000 new haematology malignancies diagnosed every year in Australia. And the mainstay for cancer treatment is the intravenous administration of antineoplastic therapies for this particular patient cohort, and that most cancer patients at some stage require venous access. But unfortunately, CVADs also come with inherent risks, and as 15 to 66% of CVADs fail prematurely, we know from the international literature. So that's as much as 2 in 3. So, and also, what we also know is that cancer patients are amongst the highest risk cohort due to the pathophysiology of neoplastic disease and also the side effects of treatments. But what we don't know is that why our devices are actually failing. We know from evidence that there are a diverse range of reasons why CVADs fail. Infection is probably the most researched topic in a particular or specific patient populations, and also with specific devices. The second most common complication is occlusion or blockages of the device, and also deep vein thrombosis. However, the only mandated reporting data for CVADs in Victoria relates to infections of these devices in ICU settings. We currently have no idea how many CVADs are being removed due to occlusion, skin impairment, accidental catheter removal, catheter migration and tip malposition, local and systemic infection, device rupture or damage, extravasation and infiltration, and deep vein thrombosis, which are causes for premature CVAD removal. And they are the reasons we have the greatest potential for impact and prevention. The impact for the inpatient can include pain and distress, inconvenience, cost, reduced access to viable veins for future treatments, and potential breaks in treatment, which can also impact clinical outcomes. The impacts at a system level include financial impost of device reinsertion, pharmacology costs of thrombolytic medications to break down occlusions, systemic antibiotics for infection or anticoagulants for the treatment of thrombosis, medical imaging for diagnosis of complications and for reinsertion of new devices, as well as staff costs, overnight stays, and theatre costs, to name just a few. But there is no robust data available to help address what is likely to be a significant burden on the Victorian healthcare system. And so, in response to the absence of knowledge and evidence, I'm undertaking PhD to explain and explore the rates of and reasons for premature CVAD removal in haematology patients attending 5 of the 7 VCCC clinical partners, which includes Peter MacCallum Cancer Centre, the Royal Melbourne Hospital, Western Health, St Vincent's Hospital, and Austin Health. And these healthcare services were selected as they incorporate the haematology services, which represent the majority of the haematology patient cohort across Victoria. I'm very much in the beginning of my PhD, as my candidature started on the 10th of February this year. My plan at this point is to undertake an explanatory sequential mixed methods study. This means a study where quantitative data are collected first to explain a situation. For example, how many CVADs have been prematurely removed, followed by a qualitative exploratory phase to help explain in depth why the situation is as it is. The strength of this design is that it allows for the generation of data that can inform tailored interventions that can be targeted to contextual, behavioural and structural issues that result in the problem or situation under investigation. And this will be my postdoc work. Using a mixed methods design allows for breadth of exploration of clinical issues in a dynamic, complex healthcare environment, and allows for the breadth of understanding of multiple confounding factors, which is essential in the exploration of vascular access management. This is my early study design plan. Phase 1 includes the collection of these variables. Inclusion criteria include adult patients with haematology malignancies who underwent a CVAD insertion between the 1st of January 2018 and the 31st of December 2019 in the 5 hospitals in the VCCC, and including all types of CVADs, which primarily there are 4, including peripherally inserted central catheters, PICCs, implanted portacaths, tunneled cuffed central catheters, and also central venous catheters. Each of the 5 participating hospitals will be considered a separate case, where the data will be analysed and considered within each context, but also across each context. Data will be retrieved from medical records through patient level and hospital administrative data sets. Phase 2, this phase is an exploratory descriptive design. Semi-structured interviews will generate data to enable and explore contextual, behavioural and system level impacts on CVAD management. Patients, nurses, doctors and interventional radiologists' experiences and perceptions of reasons for premature CVAD removal will be explored to identify clinically relevant interventions to improve patient and system level outcomes. So the purpose of my PhD is to improve vascular access outcomes for Victorian haematology patients. My PhD study design will provide me with the essential information to design a future robust implementation trial of novel CVAD management techniques to positively impact outcomes for the Australian haematology patients. Thank you.
So thank you very much, Kerrie. My apologies for having trouble coming in to welcome you, but thank you, Zoe, for stepping in so gallantly. Kerrie, thank you for giving us a nice, clear summation of where you think the next sort of 3 years are going to go for you. I'm just going to go into the Q&A section to see if there are questions there. Jenny's just thanking you for your presentation, but I might just ask a question, Kerrie, while people perhaps are thinking of their own. That first piece of work that you have that is very much quantitative, the explaining piece about reasons for removal, what are the kinds of issues you think you're likely to come up against, given that you'll be reliant on hospital administrative data sets to be able to get at that data?
So in regards to the actual data itself, primarily it will vary across hospitals. So one of the difficulties is that there'll be an electronic form in some organisations as well as written in other organisations. So that'll be a complex way to collect the data in the first instance. And also particularly we know from vascular access documentation that missing data may also be a confounding factor for issues for actual data collection. So yeah.
Thanks, Kerrie. And Jenny Phillips has just put a great question here. So Jenny's asking, I wonder if you might consider doing a piece of mapping of the clinical pathway of a series of patients who have successful and also removal of catheters. Sometimes it can be really fruitful to understand, including aspects of care at home, for example. Great question, Jenny.
Absolutely, that is a very pertinent and very pivotal way that we could also detect the issues and systemic and contextual issues within an organisation to find out where the barriers or the factors that are impeding a successful sort of transition from insertion through to removals for a CVAD. So absolutely, that is a very pertinent process and order that we could include.
Yeah, and I think just to, to sort of build a bit further on that, I think the points you bring up, Jenny, are really important in that, we lack visibility once people are home with their lines. We lack visibility of about what's happening to those lines, who's accessing them, what some of the issues may be. So having that ability to follow people out into the community, I think, is a really important one. And Jenny suggesting perhaps this is a follow-up piece in the event that there is a site that has a higher rate of infection. Absolutely. And, might there be exemplar sites that you might want to follow and, others where there may be higher rates of infection? So great. So
Yes, absolutely, Mai. And those contextual factors and the behavioural and the systemic factors of each of the context will be very much individual to the individual healthcare organisation. So what might be apparent in one organisation might not be the same in another organisation. So that's why it's very important to actually understand implicitly the factors impacting the individual healthcare services, as well as then also looking at broadly across the 5 sites as well, but understanding that primarily in each healthcare organisation is very important.
And there's a question here from further on. How much briefing is given to patients about how to behave in regards to these lines once they're back home, and how much compliance with advice is there? That's a great question.
Absolutely, absolutely. It's very interesting how much and when and where that this education for patients actually exists. It's quite interesting that vascular access is a clinical specialty that is often, it is, well, within the Australian context, is not a specialist clinical specialty on its own, where we know from the States and in Europe and the UK that there are often clinical specialties that actually surround this as a separate entity. So we know it is a clinical specialty that actually goes across all clinical specialties, but it's not the particular focus for any one specialty. So it can be lost in the trajectory of a cancer patient's journey. So it would be interesting, and it will be interesting, to explore the education and from whom, and the impact of that as well, and the impact of a potentially a continual education of a patient through the device journey, from insertion through to maintenance, and detection of complications and management of complications through to their removal.
And I think, Kerrie, so it's a really important question, isn't it, about that issue of how do you, you know, focusing on that, particularly in that qualitative phase that you have as the second phase, about when are people educated, what are they told, and what is the variation in the advice they're given. I think, Fred, you know, the question about how much compliance is with that advice is there, we really don't know, and it is clearly a huge issue in terms of then being able to make any assumptions about the quality of care that's given within the hospital setting. So that'll be a really important part of that qualitative piece, I think, Kerrie. So great question there. We've got a minute or two again if there are any other questions. Again, while people are thinking, I'll just make sure I haven't missed anything. So a question from Jane here. Do any of the hospitals have a vascular access nurse role? Great. Good question. Kerrie, I know you feel very passionately about this, so I will hand it.
Absolutely. Thank you, Mai. Thank you, Jane, for your question. Yes, we do have in 2 of the healthcare organisations, there are nurses that are involved with the insertion of some of these devices, and vascular access as in a team and management of a vascular access device, unfortunately, is not very prevalent within the Victorian or actually Australian healthcare system. How it is prevalent in, once again, internationally in the UK and the US and through Europe, of whole vascular access teams that and they manage not only insertion, but they are an expert team to manage the device and to be consultants across the life of the line. Some of our devices with oncology, in oncology, for example, these devices can remain in situ for 5 and 10 years. So that trajectory of time the patients can be at risk for significant CVAD complications. So we're very in our very infancy in this in Australia, but it is something I do feel very strongly that to improve our patient outcomes, there needs to be a focus on vascular access. from insertion of the most appropriate device in the first instance, and the management and proactive management of the device. As we were talking about before, the patient education and the early detection of complications, which caught in the early stages can prevent significant mortality and morbidity for the patient. So absolutely, it's sort of, I think there's a lot of room to grow within the Australian context for vascular access team management.
Thank you, Kerrie. I'll just wait a moment in case somebody else puts oh yes, we'll just take question from Anne as the last question, given the time. Are you looking at time of removal, so during active treatment versus maintenance stage?
So yes, actually the time of removal will be included in regards to when in the treatment cycles and when during the trajectory of their treatment it will be removed. We know this is complicated for oncology patients. The evidence tells us that we need to remove a CVAD as soon as it's no longer required. But we know with cancer therapies that these their journey, cancer treatment journey, is often prolonged and quite complex. And we also know that the vessel depletion of inserting and removing devices regularly is significant in vein depletion. So that is a significant factor that we'll be looking at and exploring the impact of. Yep, indeed. Thank you.
And I think for me, touching on Anne's question, Kerrie, is that issue of not only, looking at time of removal in terms of stage of treatment, but also looking at, what happens with the different devices. So a port, for example, different perhaps to, a PICC line or whatever. So thinking about how we also take account of all of those different variations that happen for people. So we may just leave it there. We're right on 11 o'clock. We have got another couple of minutes if anybody does have another burning question. Kerrie, something that strikes me before we sort of tie up is, as we see a change in therapies and we're moving, we're seeing more and more oral therapies, do you think that this is going to be an ongoing sort of issue for people having cancer therapies, or do you think that having vascular access is something that we will see as becoming less prominent? I'm asking you to look into your crystal ball there.
Absolutely. At the moment, intravenous administration, particularly of the anti-neoplastic therapies for the haematology patients, is the mainstay. So what we have at present time is and remains to be intravenous. Also, with our data also shows that is increasing, the number of diagnoses that are increasing every year. So I think we will maintain a significant vascular access requirement into the future, and I think how we manage that is the impact and the focus of what we need, rather than the volume. It'll be the actual impact of how we manage these devices in a fashion that improves the actual patient outcomes. Every time that we insert a device and then it's removed prematurely, has significant impacts for the patient, for the vessel health preservation, for future treatments, for future access. And then also, we know in a paediatric context that it actually can impact 5-year survival rates. So I think the evidence-based management of these devices will be the focus of our vascular access endeavours and research in the future.
Thank you, Kerrie. That's great. So I'm aware of the time. I'd like to thank you, Kerrie, for your seminar. I think, having started at the end of February, it was very brave of you to come forward so early in your candidature and start sharing ideas. But I think already seeing from the questions that have been put forward, you know, there are lots of issues to think about, and really great then that you're beginning to start this dialogue and getting to people's questions and ideas early on. So well done. We wish you all the best, you know, as you go forward, and we'll have you back later down the track to tell us how you're going. So thank you, Kerrie.